All right. Well, welcome everyone to the CCF ECMO Journal Club. Topic today is anticoagulation for ECLS. How little is just enough? One of the featured articles is listed there. Our discussion today is with Ben, Mike, and Sara. And this will be your QR code for CME. It is available only for the live event. I'll show it again at the end of the event. You basically open your phone, use the QR code. It takes you right to the site. And the session is being recorded. It will be posted to our YouTube channel. I apologize for the coloring not coming out very well. At the bottom is the link to the YouTube channel, but you'll also be emailed the link as well. It does house all of our prior events also. And with that, I will turn the screen over.
Sarah, are you able to see your slide?
Yes, I can see them.
Sarah, if you want to jump in, I'll go ahead and fill in after you go through your slide deck.
Okay, sounds good. All right, hi everybody, I'm Sara. I'm a senior perfusion student, recently hired. Will be starting as staff in a few months. Patrick gave me the opportunity to present here today, and I'm happy to be here. So today I'll be briefly discussing the article that we are looking at today, feasibility of veno-venous extracorporeal membrane oxygenation without systemic anticoagulation. All right, so just a few things. We know that veno-venous extracorporeal membrane oxygenation, known as VV ECMO, is used for life support for the lungs. Acute respiratory distress syndrome, it's a bridge for transplantation, flu, COVID-19, pulmonary embolism, worsening COPD, and other infections, and chest trauma. A little bit of background here. Traditionally, after VV ECMO placement, anticoagulation therapy is initiated. Usually it's either heparin or bivalve. It does though increase the risk for gastrointestinal bleeding and more blood transfusions. And some recent studies have showed that lower levels of anticoagulation can be used in veno-venous ECMO support. And advances in circuit technology, such as the tubing, centrifugal pumps, and newer oxygenators do help with this. So the goal of this study is to determine the safety and feasibility of VV ECMO without continuous anticoagulation therapy. The data did suggest that if you do not use anticoagulation therapy, there's reduced bleeding and reduced blood transfusions. So to discuss the patients and methods here, this was a retrospective study. The only adults placed on VV ECMO between January 2015 and February 2019 were selected in a ECMO database. 23 of those patients were excluded to avoid confounding effects, and those confounding effects were pre-ECMO conditions such as DVT, PE, hypercoagulable state, and patients who required conversion to VA ECMO. And 38 of these patients received anticoagulation therapy with heparin or bivalirudin before June 2017. And after that, I believe they changed their practice. And the activated clotting time for these patients was 160 to 180 seconds. 36 of these patients were without anticoagulation therapy after June 2017. Although they were not receiving heparin or bivalve, they were receiving 5,000 units of sub-Q heparin for DVT prophylaxis in the ICU. So to avoid thrombotic complications, they needed to maintain the flows between 3 to 3.5 liters per minute. And the patients that were selected were maintained between 3.5 to 4.5 liters per minute for both groups, which is the anticoagulation free group and the anticoagulation positive group. So the circuit that was used for this study or on these patients is similar to what we're using now at CCF. So which is the Quadrox ID by McKay and the Rotaflow pump also by McKay, and heparin-coated tubing was used in this study, but the cannulas were not. We do not use heparin-coated tubing. So some of the post-cannulation complications, and before I start with that, they did do internal jugular to femoral vein, and they also used Protect Duo. So, and it also depended on surgeon preference and what they wanted. But some of the post-cannulation complications were new neurologic dysfunction on neuroimaging, gastrointestinal bleeding, infections such as bacteremia or pneumonia, acute kidney injury, according to the rifle classification, and daily inspection of oxygenators by perfusionists and post-oxygenator blood gas analysis every 24 hours. And the oxygenator changeout indications was a PaO2 and FiO2 of less than 250 millimeter Hg and deterioration of pulse oximetry. So I'll look at my slides here because it's a little bit small. But some of the significance, patients that were anticoagulated were demonstrated significantly more days on support. If you can see, I'm not sure how you guys are seeing this, but it's a little bit small. Up top, it says support days. The anticoagulated patients were on support for much longer than the anticoagulation-free group. And among the females included in the study, significantly more women were anticoagulated than were free of anticoagulation prior to initiation of ECMO. So anything p-value lower than 0.05 is statistically significant. So these are the two top ones in this table. So this table just basically sums up the etiologies of lung failure, and some of them were the ones I included earlier: chest trauma, pulmonary embolism, viral pneumonia, and bacterial pneumonia, and lung transplantation. So this table, if you look at the bottom here, the two top statistically significant data was GI bleeding and oxygenator changeout. And you can see the difference here in patients who are anticoagulated and were not, as 11 for anticoagulated patients and 2 for non for GI bleeding, which is quite a difference. And then oxygenator changeout as well. We had 4 patients that needed oxygenator changeout as opposed to 12 for the anticoagulated group here. So the incidence of GI bleeding and ECMOs requiring an oxygenator changeout were significantly higher than the acute kidney injury dialysis, neurologic dysfunction, ischemic neurologic dysfunction, and hemorrhagic neurologic dysfunction. So these tables were not statistically significant, but it just basically shows that there was not much of a difference in survival rates between the two groups. This one talks about blood transfusions during the veno-venous extracorporeal membrane oxygenation support. Everything here is statistically significant. The patients that were anticoagulated received significantly more packed red blood cells, fresh frozen plasma, and platelets while receiving VV ECMO support than individuals who were not anticoagulated. When you look at this table, the ones that are statistically significant are body surface area, the REST score, and platelets. So the body surface area of the patient, respiratory ECMO survival prediction score, and low platelet counts before initiation of ECMO were shown to be independent predictors of postoperative survival rates in this study. A little bit of discussion about the article. So adult patients that were supported with VV ECMO can be managed without anticoagulation therapy. Lower rates of GI bleeding and blood transfusions were found in this study. Anticoagulation positive groups had higher oxygenator changeout and failure, less cannulation site bleeding, and they mentioned that this was because they had purse string sutures around the cannulas. And fluctuation of doses, cessation and reinitiation may cause more oxygenator clots. And I put in parentheses unit management because sometimes I'm a nurse as well. So I do know that sometimes we have to pause the heparin or the bivalve to take lab work. So maybe that might contribute to clot formation because sometimes we have to pause it for a little bit longer, maybe about 10 minutes sometimes. Oxygenator failure. Longer is related to longer duration of ECMO support and fewer blood transfusions in the anticoagulated negative group. The anticoagulated free group, the flows must be maintained at least 3 liters to reduce clots. If flows are lower due to hypovolemia, then anticoagulation therapy should be considered. So some of the study limitations, it is a small group of individuals that were selected for the study. It was only done in a single center and source of bias due to retrospective design of the study, and it wasn't randomized. And this study can only demonstrate improved clinical outcomes with anticoagulated free VV ECMO support. So we do have, I'm going to talk about softline and bioline. Softline is what our tubing is coated with, all our ECMO circuits, and it's heparin-free, and it is a polymer comprised of hydrophilic and hydrophobic areas, reducing the surface area, the surface tension on the contact surface, and this is just a picture of what it looks like. And we also have bioline, which is an option you can choose, but we use mostly softline. It is covalent bonds between heparin molecules and the albumin layer, homogeneous surface that demonstrates preserved platelet function, and it reduction in clotting activity, thrombus formation, and decreased activation of the complement system. I'll talk a little bit of our circuit. This is the rotaflow here that you see on the left. And we have the centrifugal pump here, which is softline coating. This is one of our oxygenators. This is the Quadrox ID, the same one that was used in the study. So this goes up to 7 liters per minute. It is polymethylpentene fibers. It is also softline coating or bioline coating is available. And the heat exchanger is polyurethane. So none of these are heparin coated. Our next one is the Nautilus, which is fairly new. I think we started using it back in June. It's made by Medtronic. It's the Nautilus ECMO oxygenator. This one is balanced biosurface. It is hydrophilic polymer coating without heparin for cardiopulmonary bypass circuit devices. This coating reduces platelet adhesion and activation and preserves platelet function. It is also polymethylpentene, but the heat exchanger is a little bit different. It's polyethylene terephthalate, PET, and the tubing is softline coating. So our tubing is made by Medtronic, and it's softline coating. These are two of our pump heads here, not all of them, but these are the ones we use for ECMO. So the one on the left is a Rotoflow centrifugal pump. It's soft line coating, and you can see it here in the motor. And on the right side, you can see the Medtronic one, which is called the Affinity CP, and it has balanced biosurface. Any questions? It was a little bit short.
Thank you, Sarah. I think you did a great job summarizing the article, and I think especially the information that you provided at the end regarding our different circuit and oxygenator materials really helps to set the table for the types of discussions about how much or what the optimal intensity of anticoagulation, or if anticoagulation is needed at all in ECMO. And so I think that's really important information to have to frame the context of some of these discussions. So, yeah, so I think I'd like to share a couple more slides that highlight some of our Cleveland Clinic experience here with regards to patients that were on versus off anticoagulation, and then use that to open it up to a little bit more broad discussion about anticoagulation practices in general in ECMO. Penny, do you have my slides? I'm sorry.
Are you not seeing them?
Not yet.
Oh, okay. Let me maybe exit and then try and share again.
Perfect.
Great.
So as Sarah mentioned, ECMO is going to introduce both hypercoagulable effects as well as potential for ECMO-induced coagulopathy. And ultimately, our decision with regards to whether or not we anticoagulate a patient who's on ECMO and the intensity of anticoagulation is going to be a balance between these two different factors. The most recent guidelines from ELSO are back from 2014, so don't necessarily reflect all of the most current data that's out there regarding anticoagulation practices, but in general, they do recommend routine anticoagulation during both ECMO cannulation as well as post-cannulation. And you can see that there are some notable differences between both what was done in this study as well as what we generally see in terms of our practice at Cleveland Clinic, with use of ACT as a primary monitoring strategy, as well as some differences in the intensity of anticoagulation compared to what we typically will see with our patient population. As we've alluded to, there's a growing body of literature that describes decreased intensity of anticoagulation in ECMO. A lot of that started with individual case reports or case series of anticoagulation in patients who are not able to be anticoagulated. And as we've progressed through the years, we see an increasing number of trials that describe anticoagulation free ECMO runs in both VV and VA ECMO patients. There's a number of different trials, but as I mentioned, it's important to highlight that this is both VA and VV ECMO. So when we start to look at our Cleveland Clinic experience, we actually performed a similar type of review to what was presented today by Sara, but I'll highlight some of the differences between the data that we reviewed from the recently published study and what we've seen here at Cleveland Clinic. Our study here looked at patients from 2015 to 2018 who were on VV ECMO only, and compared patients who received systemic anticoagulation to conservative anticoagulation, which we defined as being anticoagulated for less than 50% of the time that they were on ECMO. Now, this was not a pre-post study like it was performed in the study that we looked at today. Ours were just evaluated throughout the time that during the study period. So there were more patients who had either bleeding prior to being placed on ECMO that were in the conservative group, or were deemed to be at high risk for bleeding, and that's why they did not receive systemic anticoagulation. I apologize, this is a little bit small, but overall what we saw in our experience here was relatively similar to what was observed in the trial that we just went through, in that there was not a difference in the rate of oxygenator exchange that was observed with our conservative anticoagulation strategy compared to those patients that received systemic anticoagulation. Where we did differ slightly was that rates of hemorrhage were actually similar between the two groups. And again, that may be somewhat due to the fact that patients that were in the conservative anticoagulation arm were likely at higher risk for bleeding going into their time on ECMO. And as such, we did not observe any differences in transfusion requirements between the two groups. There is ongoing work to reevaluate a similar type of study looking at what our results have been for this patient population, because since the time that we evaluated our experience from 2015 to 2018, we've largely shifted to withholding routine systemic anticoagulation in our VV ECMO population. I think some things that are important to highlight, though, from this trial and where there may be some differences compared to what we typically see within our patient population is mostly with regards to the types of patients that were placed on VV ECMO in the anticoagulation-free arm, as well as how long these patients were actually requiring VV ECMO support. And so I think if you're able to take a look back to Table 2 within the trial that we reviewed today, the etiology for lung failure, I would say, is somewhat different from what we would see from our typical patient population for VV ECMO here at Cleveland Clinic. And especially when we come to the number of days of support, I think that's the biggest thing that I find to be a challenge in interpreting the results of this trial. We see a median duration of support of VV ECMO in the anticoagulation-free arm of just 4.5 days. And so I think that really calls into question how much we can take away from this trial, given that this is a fairly limited duration of support. And questions that I have would be things like, is that sufficient time for there to be a high risk for oxygenator failure? Are some of the potential hematologic abnormalities or ECMO-induced coagulopathy going to develop in that shorter duration of time period that a patient's on ECMO? And would some of the clinical outcomes that were described have necessarily played out if these patients were on VV ECMO for a longer duration of time? So I want to open it up to the group now to see if there's any other generalized thoughts before we start to move into some of the more ongoing areas for controversy.
No, Ben, I think you touched on a very important point in that, this is a very sort of select patient population that doesn't necessarily apply to what we see at Cleveland Clinic. And the fact that the median duration was only 7.2 days, and in the anticoagulation-free patients, that was actually even less, 4.6 days. So you're exactly right. It's hard to sort of extrapolate that to our experience and maybe other centers. I think it's really important to state that in our experience as well, we try to surveil for the development of any kind of DVTs or any other things that might lead us to then cross over. And there was no mention of any crossover between these two groups. But again, the amount of time was fairly short, as was the kind of long-term, the follow-up, which is about 3 to 4 months, assuming that they didn't say this explicitly, that all of these patients survived to, decannulation and all survived to hospital discharge, which is, again, different than what we would see at our institution or a lot of centers would see.
Yeah, I completely agree. And I think especially the surveillance for ongoing thrombotic complications and even post-decannulation is something that needs to be emphasized, particularly in an anticoagulation-free anticoagulation strategy. You can see that while it was not statistically significant in our population, there was a numerically higher number of patients that did develop deep vein thrombosis. And the majority of those were identified actually post-decannulation in our experience here. And so I think that's a phenomenon that's been described regardless of anticoagulation strategy and regardless of VV versus VA ECMO. And so it would have been helpful to have further evidence either supporting that or disproving that from this trial that we presented today.
Right. No, exactly. And they don't talk necessarily, they didn't go into the granular details in terms of what size cannulas they used with dual site cannulation, nor the size, of the Protect Duo, which is, an interesting selection to use that alone as their single site dual lumen cannula, where we use either Avalon or Crescent, and less likely to use a Protect Duo, which is again another sort of point of difference between our group and their group. But it looked like Dr. Morales had a question he wanted to ask.
Yeah, thank you, Alex, and thank you, and Sara, for presenting. The main question I had is obviously these retrospective studies suffer from a lot of biases, and in specific, it's hard to come to terms with the things that we're trying to prevent by anticoagulation, which you put there on your list. And so it made me think about two things as I look at this. The first one is the incidence of ECMO-related coagulopathy, and how do we define it, and how do we measure the incidence between those two groups? And the second one is this seems to be ripe for a protocol for standardized screening of these patients that are on that arm. I will tell you that just from our practice here at the MICU, when we started doing the peripheral neurepi, the literature reports very low extravasation rates. But when you put your eye onto it and you create a protocol around it, you realize that these things occur much. I mean, they are not. They are without consequence technically, but we are able to capture them better. So if there's a protocol that you capture these, there may be a lot more that you will capture, that but without any management change on the care of the patient. So I think that it goes through those three levels. One, what actually are we doing by stopping? The second is how much of these problems are, and number three, does it actually impact the care of the patient? That's my comment. Thank you, Ben and Sara.
Yeah, I think those are all great points. And I think especially your comment regarding routine surveillance and whether we're simply identifying adverse events that would have been present had we been anticoagulating or not, or had we been surveilling or not, is especially important too. And I think when you look across all of the literature in terms of DVT prophylaxis in medical patients and surgical patients, that's something that's been shown to be the case as well. So I think would only be magnified in a patient population like our ECMO population.
This is Mike Militello real quick. I think one of the other things that's important to think about too is the fact that there is really not a standardized approach for anticoagulation. I know, Ben, we're going to get into this a little bit more, but the level of anticoagulation is potentially as important as anticoagulation alone. And so I think that those issues too are very important when we're looking at these patients.
Yeah, absolutely. And Penny, if you move forward to some of the ongoing areas of controversy, I think the question of is anticoagulation required for all patients on ECLS? I hope the answer is no, because we have not been doing that for the last 2 years. But I think then the question becomes, if not everyone, then who? And then, as Mike alluded to, what is that optimal intensity of anticoagulation that's needed? And I think there's not necessarily going to be a one-size-fits-all to that question, but I think definitely an area for ongoing discussion and debate.
Hey, this is James. Great talks, everybody. Have you gotten to the topic of the 10A versus PTT for monitoring?
That's next.
We're getting there.
Okay. Sorry.
Are we going to launch into a little bit more VA discussion here as well, Ben, or not yet?
I was going to
Absolutely.
ask, I was going to ask,
Absolutely.
at this point with anticoagulation differences between VV ECMO versus VA ECMO and the potential sequelae from VA ECMO potentially could be worse than from VV ECMO.
I think absolutely, totally two different beasts, especially if we think about stasis within the LV and, just the thrombogenic. I always end up showing a slide when I present on VA of thrombus developing within the LV secondary to stasis. So I think they are two different beasts. Mind you, a lot of the time we do run VA in the setting of catastrophic bleeding or, immediate postoperative bleeding, and we will, stand down for a period of time while we wait for coagulopathy to resolve. So how long is a safe period or not, I think, are, ongoing questions as well. It's risk balance.
Yeah, I also think it's challenging too, as we put people in ECMO and the changes in coagulation factors, von Willebrand's factor, et cetera, that the bleeding, the potential for bleeding is maybe different depending upon early versus later on with ECMO. And I think that also then leads into the issue of monitoring. And we know that with monitoring, there's been a lot of issues with knowing that as ECMO drops levels of fibrinogen and other coagulation factors, that the effect on the lab values at baseline of PTTs can be elevated. And so routinely, or the question is, do we routinely use 10A assays as the PTTs are many times elevated, then going into other ways of monitoring therapy besides the 10A. And then finally, we'll talk a little bit about the use of alternative anticoagulants, and maybe bivalve is not the best strategy for some of these patients who have hits, and maybe argatroban might be a better strategy. But I just wanted to throw that information out.
Yeah, I think especially in CVICU, we're obviously utilizing VA ECMO more in the post-cardiopulmonary bypass setting, and the bleed risk is going to be significantly different than necessarily maybe a medical patient in J31. And so I think that's where the discussion regarding the optimal intensity comes into play. And do we necessarily target the same PTTs across the board in VA ECMO, or is it going to be dependent on how far from surgery the patient is? And then, as Mike alluded to, what are the ECMO-induced changes in coagulopathy that occur over the course of the patient being on ECMO as well?
I think right now within our ECMO order set, are we going towards 10As or PTTs?
My preference is 10As. And the reason I prefer the 10A is because of the fact that there's less interference with the 10A than there is with the PTT, giving you a potentially, I guess, easier and more reproducible target for these patients. I think at the same token, we have to think about what the unit per kilo dose is for patients as well, because I think we have to balance that versus patients who may be heparin resistant, and when do we decide to look at antithrombin levels. But I think in our current practice, my preference is for, at least for the VA ECMO patients, is to use the 10A assay as opposed to the PTT, as the variability is much less in patients.
Practically speaking, I found for just titrating at the bedside in terms of nursing, that being able to use a nomogram that allows for PTT monitoring is sometimes a little bit easier. But, when there is discrepancy, I definitely do go between, drawing a simultaneous 10A and PTT to look for stability there. Yeah.
Yeah, no, that's great. One of the things that we're working on is developing a 10A monitoring algorithm, nomogram, The challenge that we have is the global utilization of a 10A nomogram can be quite difficult based on the fact that patients who are on medications that are the oral direct thrombin the oral factor 10A inhibitors have huge interference with the 10A assay for heparin. And the issue is if we were to roll out right now the use of a 10A nomogram, then a lot of people will go over to that 10A nomogram, regardless of the patient's baseline characteristics, if they needed a PTT or the 10A. And because of that, our lab at this point would not be able to, because it takes 2 hours to manual run right now. As we go toward looking at utilizing the 10A as a standard, the instruments can be tooled that we have currently to do 10A assays automated like we do with the PTTs. So we're trying to right now working on the logistics of how do we identify patients coming in from the outside or home on 10A inhibitors, and then making sure that we aren't having interference with that when we're monitoring therapy. Does that make sense?
So one other thing I just put into the discussion box is that this is something that we struggle with quite a bit in the CTICU, is that while as opposed to medical patients, surgical patients have a lot of additional reasons that they might be bleeding, and also bleeding can cause some very serious issues for, post-cardiotomy patients, etc. And so while the anti-10A reflecting the pure heparin effect may be less than gold, the patient is clinically bleeding from everywhere, their PTT is high, and so we can't always use the anti-10A to guide us from that standpoint. And so that's why, I don't know if we're going to talk about that more in the slides to come, but I think it's nice to have the two perspectives in terms of anti-10A being very helpful in certain patients, but in others may not be quite as straightforward.
So I agree with that completely. And I think that's where in that patient population, sometimes the TEG can be a little bit more helpful as well.
Yeah, absolutely. I think it's not something that we've necessarily built into our routine practice for monitoring of patients who are on therapeutic anticoagulation. I see us using TEG mostly now in the setting of patients who are actively bleeding and off of anticoagulation and trying to determine optimal repletion strategies. But I think perhaps, as you alluded to, there's an opportunity to use it in our patients that we are therapeutically anticoagulating to determine how much of this is intrinsic coagulopathy versus how much is due to the fact that the patient is on systemic anticoagulation.
I agree.
And to address Dr. Morales' question, is that sometimes it's kind of a moving target, when the reality is if a patient is sort of bleeding from lots of various places, we know that they have some kind of coagulopathy. We'll send various things, TEG, fibrinogen, PCT, ACT, we'll send all of it, and it can be a whole spectrum of different values. And so it's kind of hard to put your finger on just one thing, knowing that ECMO and ECLS, the circuit in and of itself, can cause certain factor derangements like von Willebrand's factor and things we just described, but then patients can have other things. So it's hard to separate what is just ECMO coagulopathy. I don't know if Ben or someone else wants to expand more upon that, but
don't you think that it would help us define who gets what? There must be a definition for this type of coagulopathy. I mean, and I understand that part of it is because of bleeding, but there must be a pathway to define and say, this patient is coagulopathic, and it may be clinical just by the bleeding that you see, or else. I don't know.
I think, and I think, and I'll just real quickly say that a lot of times we'll sort of run the TEG and see what factors that we need to replete, be it fibrinogen, be it cryo, be it platelets or something like that, to try to have more targeted repletion, where it's a little bit more challenging to say what is the exact etiology. Is it just consumptive coagulopathy secondary to the ECMO, or is it something else? ELSO, kind of defines coagulopathy very broadly and more in terms of what's the end effect. Like, do they get transfused more than 2 units of blood, for whatever 24 hours? And so most of the definition is based upon how you address it as opposed to what's actually going on.
And I think that's important to know is with anticoagulation and also with monitoring, there really hasn't been necessarily a standard across the board. I think ACT has been the standard for a number of years. PTT crept in as a standard, as it's an easier sample to get outside of a OR or a procedural area, at least at our institution. And then the now looking at 10A assay. So I think that there hasn't been necessarily standards for that, which I also think makes it a little bit difficult to know what the best approach for monitoring is as well. The other thing I wanted to bring up too is, and we've seen this multiple times in the coronary intensive care unit, and that is, and it's not just with ECMO, but with other circulatory devices, and that is sampling error and sampling methods, where we have patients who depending upon what devices they have in and what anticoagulation is going on, that we have issues with inappropriate draws, or I won't say inappropriate. How about contaminated samples because of maybe not necessarily always knowing what and where the heparin or bivalirudin is going, and we've had a few occasions where we've had patients on ECMO as well as Impella, and there's been situations where drawing samples is very challenging because you have the purge solution of the heparin going into the Impella, and then you have systemic anticoagulation with the ECMO, and because of that, we're getting potentially contaminated samples where PTTs and 10As don't make any sense as they're very high. So that's another factor to keep in mind is making sure we're doing correct sampling for monitoring.
That's a great point.
Dr. I didn't want to cut you off. Was there something else that you wanted to add?
No, I just I think it's interesting if you sort of run through the literature on both VA and VV. There are seems like there's more papers or abstracts or small series popping up that talk about ECMO without anticoagulation. So I think our institution has answered that first question pretty well. It's definitely not required in all patients in all situations. There seems to be some interest in testing out situations on VA ECMO without anticoagulation. There was a paper that came out of the Annals, I think, from University of Rochester that describes a comparison between some group of patients that had VA ECMO without and with anticoagulation, and they found no major difference in mortality, pump failure, thrombotic complications, without really knowing the small details on that. I think what I'd love to see is if we could get to a point where all of our circuits, cardiopulmonary bypass circuits in the OR, ECMO circuits at the bedside, had reduced need for anticoagulation overall membranes. That's going to take technological advancement and some time.
Yeah, absolutely. And I think we're jumping around a little bit, but I think an important question is in the patients that we're not anticoagulating off the start is what is our impetus to begin anticoagulation? And I think Dr. Briberesco highlighted that question as well. Is it clotting within the oxygenator, the need for oxygenator failure? Is it some of that routine surveillance for DVTs that Dr. Morales was mentioning? What is it that would drive us to switch strategies and begin anticoagulation, or do we accept some of these potential sequelae related to being off anticoagulation, knowing that they're a possibility?
Hi, Ben. This is Sudhir Krishnan. Ben, great job with the presentations, and so with Sara. 2 cents. So we've had over close to about 66 patients on VV ECMO. The question is, are we doing our patients a disservice by discontinuing anticoagulation? We have data from 2015 to 2018. 2019 was an inflection point where in which we changed our practice. We've got over 120 patients now. It's imminently possible for us to do a propensity match analysis. The question is a cheap way to do a randomized control trial from the data that we have. So that question can imminently be answered. More importantly, our outcomes, we have a 66% survival on VV ECMO per our 2020 data. So we essentially haven't done our patients a great deal of disservice because our outcomes are better than from the previous years and better than from what ELSO has reported. So we are on strong grounds. The only true way to truly answer the question is to do a randomized control trial. And we've got enough data from what we have to come up with a number required to power a trial, if that's how we want to do it. Whatever we discuss is retrospective. It has its biases. You take it with a pinch of salt. But for those of us who are practicing it day to day at the bedside, you've noticed that a change in our anticoagulation practice has yielded a whole lot of results. Bleeding doesn't seem to be a big issue anymore at the bedside, which is reasonably common in early 2018. Every Monday, there's a discussion that, hey, listen, should we scan our patients? Let's scan our patients. And then, we follow those patients through. They have DVT. If it's extensive DVT and if it's indication for anticoagulation, then that's considered. If it's superficial, we let it be. That's what our practice has been at the bedside. As far as oxygenators are concerned, oxygenator failure itself has never been the case. But tomorrow in the M&M, I want to bring up a case, and I want to save it for this discussion tomorrow, actually, where it's a great segue for this discussion as to when do I consider anticoagulating someone, and what should be the level of APTT or ACT or factor 10A for this for a given patient once we begin the anticoagulation. So I'm kind of sold out, on the fact that, at the Cleveland Clinic, VV ECMO can be safely practiced without anticoagulation. There are multiple, measures in place that allow us to the Monday morning check the DVT, the daily rounds where we check the oxygenator. Those things can be taken care of. So I would persist for us to continue with that. But if we really wanted to do it scientifically, the only way to do that is to do a trial. But the simplest thing right now, Ben, would be for us we have a large cache of data. And that's something that we need to peruse a little more closely. And I think with over 200, 250 patients, that's probably the largest database of patients without anticoagulation that we'll be able to present. And we can pick and choose into a proper propensity match analysis, which I think we should invest in. We should definitely invest in that. That would be the first step for us to do. As far as VA ECMO and no anticoagulation, let's leave that for discussion tomorrow with the M&M, because we have a fabulous case that we just have to discuss. But that's an M&M case. And then with Eduardo's concerns about ECMO coagulopathy, Eduardo, that's a tough question to answer. If the patient does not have anticoagulation, we know for a fact, at some point the oxygenator is going to build up clots. As the clot propagates, it's going to consume the platelets and it's going to consume the fibrinogen. Whether it results in an patient-associated bleeding, it's a great question to ask, but I don't think we have clearly defined that. Hey, listen, the clot is building up in the oxygenator, that's consuming the platelets and the fibrinogen. Now the levels of the factors are low. The patient is in a profound state of anticoagulation. Is the patient going to bleed? That's a question that's not been clearly answered. Just like we have not answered the question of whether an oxygenator thrombus can be considered as hit because of heparin. So that's something that we can explore, but I don't think we'll be able to get to the bottom of that. If my patient has any episode of bleeding, GI or otherwise, and I feel that the fibrinogen level is low and the platelets are less than 50, it'll be very hard for me to argue that it is not because of ECMO. I mean, I would keep that simple. And then my ideal would be to replace the clotting factors and find an etiology as to why the patient is bleeding. I don't know whether that answers the question, but that's the best that I can come up with.
I think it's a good idea to keep thinking about that question that Eduardo brought up, because depending on the mode of ECMO, the patient's other clinical issues, ECMO coagulopathy for a J31 patient who got hammered with, Plavix and 2B3A inhibitors is something different than what we might see for a VV patient who's got alveolar hemorrhage. But I think it's an important question to define vicinity, and it probably has a different morphology for different situations.
No, James, that's a great point. What I was alluding to was the idea that a circuit, a mechanical device, can result in a coagulopathy because of consumption of clotting factors, as opposed to a pharmacological agent that disrupts your clotting mechanism, you see. So if Eduardo's question alluded to the idea that a mechanical circulatory support device, because of an impeller, because of a pump, because of a tube, can result in product consumption, then that's a completely different etiology. And that's what I thought Eduardo was trying to define. I mean, you could have a patient on GBTB3 inhibitor, you could have a patient on Coumadin therapy, on ECMO, and that could complicate the episode of bleeding. But what I thought Eduardo was alluding to was ECMO, the instrument itself, the mechanical pump itself. Does that propagate the idea of coagulopathy as evidenced by clot formation and consumption of clotting factors? Eduardo, is that what you were trying to ask? Has he left?
I think he's managing a call right now.
Okay.
I don't know if we could just, as seeing we only have like 2 minutes left, if Mike Militello, I'm not sure if Dr. Gomez is on from vascular medicine. We had been discussing a little bit about anticoagulant management in the setting of PIP, and whether or not, agatroban bival, if we could briefly maybe just weigh kind of pros and cons about thinking about secondary agents in that setting.
Sure. I think one of the issues is understanding the difference in pharmacology between bivalirudin and argatroban. We know that bivalirudin is a nice agent because it's got a very short half-life. It actually is it's pretty forgiving even with renal insufficiency. However, one of the big problems is that argatroban itself, bival itself, has a proline-arginine bond between the exosite 1 and active site. And what that means is that drug autocleaves and actually decreases efficacy in and of itself without even the renal clearance, meaning that if you had it in a still line, at first there's anticoagulation, but then eventually that area would clot. And so the question is bival the best choice, though albeit shorter half-life, and able to be used in patients with significant liver dysfunction, versus something like argatroban that's cleared hepatically and that doesn't have that autocleaving and maintains activity as it's cleared through the liver. And so one of the questions has been, is bival the best agent for this, or should we be considering using something like argatroban in some of these cases? And the reason we bring that up is because of the different currents and eddy currents that occur within oxygenators and within the circuits themselves may lead to slight stasis of blood in certain areas.
It's a great question. It's obviously been a consistent and major concern when we use bivalirudin for cardiopulmonary bypass. And so obviously there's the same theoretical risk that would happen with any extracorporeal circuit. So I think definitely something to consider. At least I'm privileged to know that one of our pharmacy residents is evaluating our historical use of bivalirudin in ECMO patients that are HIT positive. So hopefully can shed a little bit of light on the safety of that medication for that specific population. And hopefully there'll be something to help further address that as well.
I think from a surgeon's perspective, if we have a long-termer bridge to transplant for either lung or for heart, and you end up in a situation where you've got HIT, having to use bival for the surgical procedure that the patient's being bridged to is somewhat of a nightmare. And so I know anecdotally there are some surgeons that are using bival for some of these long haul folks just to avoid HIT entirely. I mean, there are also ways to deal with HIT, like plasmapheresis, which also has some issues associated with it. But I think there's going to be more groups trying bivalirudin for some of these longer term folks.